Hello everyone, this is Muhammad Awais bin Abdul Malik. I am a first year internal medicine resident currently training at Advent Health Orlando in Florida, and I am today going to present a very interesting and challenging case that we recently encountered, and it is about Juremic stratopladal syndrome with atypical presentation. So, to briefly introduce about this syndrome, it's basically a uremic encephalopathy with chorea-like movements, majorly seen in long-standing conditions like type 2 diabetes mellitus with ESRD. As we do know that patients with ESRD are linked with high levels of uremia and they are more prone to get this syndrome. So there is classical imaging findings which we usually see with this syndrome, but the challenging part is that it is not necessary that all the patients follow this classical pattern with imaging and these associations with CKD, diabetes, and this chorea-like movement. So that is why it becomes challenging to diagnose it, and recognizing this condition early is important because it may improve with timely correction of underlying metabolic abnormalities. So we recently encountered this case, which is actually about a 64-year-old female with past medical history of ESRD, diabetes, hypertension, coronary artery disease with prior stent placement, who came to hospital with major complaints of sudden confusion and abnormal movements that were encountered by her family recently, and these findings were very acute in nature, and patient was not following any commands. As per family, they noticed these new involuntary movements in her arms and legs. They were jerky and irregular in nature and associated with tremors. There was no history of trauma, fever, seizures, or any recent medication change. So, given her kidney disease, she was started on dialysis. There was initially a temporary improvement in her condition, both mental as well as abnormal movements, but unfortunately, it did not last very long. Over the next couple of days, her condition actually worsened and she again began to decline, and then these involuntary movements, tremors with decline in mental status came back. An extensive workup was done, an EEG was done that did not show any seizure activity. LP was done that was unremarkable for autoimmune panel. Infectious disease was involved. Extensive imaging was done, part of which was CT scans, MRI, and the vascular imaging. They did not show any stroke, hemorrhage, or any major vessel abnormality. Typical imaging findings expected in uremic syndrome were not present. Instead, an asymmetric change involving the left basal ganglia, including calcification, and non-specific findings were found. She was initially treated with antibiotics, steroids, but given her condition continued to decline, she unfortunately aspirated. That resulted in cardiac arrest and she passed away. So, just to move on about this USPS syndrome and to talk about pathophysiology, it is basically associated with metabolic derangements, as we see in CKD, in ESRD, due to toxin accumulation, acidosis, and cerebral edema, which particularly affects basal ganglia functions. Clinically, patient may present with abnormal movements resembling chorea or Parkinson's, along with varying degree of encephalopathy. While MRI findings often seen in this diagnosis is typical of bilateral, but in our case it was not bilateral, it was just found on one side, on the left basal ganglia. So just to add on, there are other causes like liver diseases, infections, hypoglycemia, and medications were ruled out, which making this renal failure and diabetes is the most likely trigger for metabolic stress and derangement of our patients. So management majorly focuses on optimizing dialysis and correcting the metabolic arrangements. Medications, they play a limited role actually. Although some patients show improvement, relapse or progression can occur, emphasizing the need of close monitoring. So in conclusion, this case actually underscores the importance of maintaining a high index of suspicion for uremic stratopladal syndrome in patients with CKD, long-standing diabetes, who actually present to the hospital with acute neurological symptoms, even when all the imaging findings, all the metabolic findings are unremarkable. So, an early recognition and aggressive metabolic management are essential to improve outcomes and preventing irreversible complications. Thank you for your attention.